Good afternoon, everyone. I'll be here to share with you what we are doing at the National Tuberculosis Control Program when we are managing TB cases. So the objectives of this session is to discuss and compare the current TB treatment strategies, both in the local and international setting, highlighting similarities and differences, program strengths and weaknesses, and to discuss the current TB DOTS referral system and how do we refer suspected MDR TB cases. So when we say TB control in the Philippines, our roadmap would be the 2010 to 2015, 2016 PhilPac, or the Philippine Plan of Action to Control Tuberculosis. So this is our strategic plan. How do we control TB in the Philippines? So there are 4 objectives and there are 8 strategies. And in Strategy 5, TB in children is included. So this is to address MDR TB, TB HIV, and needs of vulnerable population. And children is included. So we did an assessment of this strategic plan since we started in 2010. If we look at the different indicators, one of the failing grade that we have would be for children. We said our target is to provide treatment or preventive therapy for 750,000 children, and we only achieved 12%. So that is for children, and aside from that, our other failing grade would be the MDR TB. For MDR TB, we are only finding 22 cases. And our challenges when we're talking about implementing TB in children is there are over and under diagnosis. So if we look at the different accomplishment of the different regions, there would be regions that are seeing a lot of TB in children. But there are also regions that there are very few cases of TB in children. Then we have the complicated algorithms. Then we have large number of recording and reporting forms. And we have problems in terms of the stability of the syrup and the suspension that we're having for TB in children. So for us to address this, we revised our manual of procedures. So this is now the latest MOP that we have. And the basis of this would be from WHO. So we have rapid advice, wherein there were changes in the dosages of the drugs. And to address this advice, we did a rapid advice also, which we launched during the PhilCat convention. So the dosages here was based on the discussion of the Department of Health and representatives from the Pediatric Society. So it was not only DOH who said that this would be the dosages that we would be using. Then aside from that, we have other issuances regarding children. So we have the 2nd edition of the guidelines of WHO, and then we have the ISTC. So we consider this when we revised our MOP. So these are the policies that we have. So all diagnosed TB cases shall be provided with adequate and appropriate anti-TB treatment regimen promptly. So when we say adequate, we introduce the anti-TB drugs for children in kits already. So although it's in bottles, but they are issued in a box wherein the full needs of the patient is already allocated. So there should be no reason for the health worker to say na naubusan kami ng gamot. Kasi we already have a kit. So the kit is not only for the adults, but also for children. Then anti-TB treatment shall be done through a patient-centered DOT to foster adherence. So DOT should be carried out in settings that are most accessible and acceptable to the patient. So before, when we say DOT, the patient should go to the health center daily, except Saturdays and Sundays. But in the new MOP, the health worker and the patient should discuss. So for children, it should be the mother. And they should discuss what is the most convenient place for the patient to take the anti-TB drugs. Okay? Then next is the anti-TB treatment regimen shall be based on the anatomical site, bacteriologic status including drug resistance, and history of prior treatment. So this was already discussed earlier by Dr. Ama, what would be the anatomical site and the bacteriologic status of the patient. Then the TB treatment under the NTP shall conform to standardized regimens. So before, and then the policy is aligned with the ISTC Standard 7, wherein to fulfill the public health responsibility as well as the responsibility of the individual patient, the provider must prescribe an appropriate treatment regimen, monitor adherence to the regimen, and when necessary, address factors leading to interruption or discontinuation of treatment. So there should be coordination from the different services, not just the public. So the treatment regimen that we have now is only category 1 and 2. Wala na po yung category 3. And when we say category 1, we have category 1 and category 1A. So category 1 would be for pulmonary TB. So these are the new, whether you are smear negative or smear positive, and extrapulmonary TB that are also new, except for those in the CNS, bones, or joints. And this time, we are using the 4-drug regimen during the intensive phase. So that is 2-HRZE and 4-HR. So before, it's only 2-HRZ. This time, we added ethambutol. Then category 1A, so this would be for the extrapulmonary TB that are also new, but are involving the CNS, bones, or joints. And this would be the 2-HRZE and 10-HR. Okay, so that is for the new TB cases, category 1 and 1A. Category 2, so we are still using category 2. So this would be for the previously treated drug-susceptible TB. So those are the relapse, treatment after failure, treatment after loss to follow-up, previous treatment outcome is unknown, and other TB cases that we cannot put a type. So the treatment is still for 8 months. So this time we included the streptomycin, then 1 month of HRZE, and 5 months of HRE. For category 2A, so this would be the previously treated drug susceptible that are having the extrapulmonary TB in the CNS, bones, and joints. So the treatment would be for 12 months. So earlier, Jennifer said that category 2 is not a good treatment regimen. So what we're doing now is we're doing a study if we really need to delete the category 2 treatment regimen. But what is good now is we are also using the gene expert, as mentioned earlier by Dr. Ama. So when we treat them for category 2, it means they are still drug susceptible, but they just have a history of treatment. Okay? So we are in the planning stage if we really have to remove category 2 treatment regimen. So that we will just say if the patient is susceptible or if the patient is resistant. So if the patient is resistant, then the treatment regimen would be the standardized treatment regimen for the drug-resistant TB cases. So I will not show that treatment regimen here. So in terms of the drug dosages, so this is for the NTP, and this one is from the WHO recommendation. So there are red marks to show the discrepancy. So for isoniazid, we have the 10 to 15, but for the WHO, it's 7 to 15. When we said that it's 10 to 15, or all the drug dosages here have been discussed with the PPS. And the reason why we want it 10 to 15, we do not want to use the 7 as the minimum because we're saying that Filipinos are fast acetylators. But the reason also for WHO why they have the 7 is because if we are going to use the fixed dose combination, they need to have the 7 milligrams. Kasi kung hindi siya 7, hindi tutugma yung mga dosages ng fixed dose combination. So they have studies to show that 7 is good also. But for us, based on our discussion with PPS, it's 10 to 15. So no problem for rifampicin. So it's the same, 15, 10 to 20. Then for pyrazinamide, for us it's 20 to 40. Actually it's 30 to 40. But we are using the 30 instead of 35 as the usual dose. So this should be 30. Okay, so then for streptomycin, for WHO, the recommendation is not to use streptomycin as a first-line drug for pulmonary TB and tuberculous peripheral lymphadenitis. But for us, when we discuss the rapid advice, we will still use the streptomycin, and it will be for the serious forms of TB and for the very young, where a fourth drug like ethambutol is not suitable since we cannot monitor if there would be adverse drug reactions. Okay, so that's the difference in the dosages. Then why did we change from 3 to 4 drugs treatment regimen? So this is based on the WHO recommendation, which says that children with suspected or confirmed pulmonary TB or tuberculosis, peripheral lymphadenitis, or children with extensive pulmonary disease living in settings where the prevalence of HIV is high and or the prevalence of INH resistance is high should be treated with a 4-drug regimen for 2 months, followed by a 2-drug regimen, HR, for 4 months. So if we look at our situation here in the Philippines, HIV is low, but it is increasing, but it is still low. But the INH resistance is high. So if we look at the latest DRS survey that we have, this is the second, done in 2012, isoniazid resistance among the new, any resistance is 14%. Previously treated, it's 36.5. Then mono resistance to INH is 10. Among the previously treated, it's 13. So yung 10 and above, it's considered high. So that is the reason why we already shifted to 4-drug treatment regimen. So other policies are all retreatment patients shall be screened for MDR-TB before initiating Category 2 treatment regimen. So we want to be sure if we start them on the Category 2 treatment regimen, we are sure that they are really susceptible and not resistant. So we need to screen them. Currently, access to our MDR facilities is better compared to 19 or 2000 since it's present in all regions but not in all provinces. So limited pa yung access sa MDR-TB treatment, but we are still scaling up. Same with the use of the gene expert. Our target is to have 1 or more gene expert machine per province or highly urbanized city. So treatment response shall be monitored through follow-up, direct sputum smear microscopy, and clinical signs and symptoms. So it's not just smear microscopy. So it would include signs and symptoms. And there should be tracking mechanism for patients lost to follow up for us to ensure that we really ensure that patients are cured. Then all registered TB patients in Category A and B areas shall be provided with HIV counseling and testing. However, for pediatrics, since we're saying in the program, children are 0 to 15. And when we discussed this with the HIV program, they said there is no need as of the moment for us to do HIV counseling and testing for children. So when we say children, 0 to 15. So no need to do the HIV counseling and testing. So in terms of case holding, so for TB program, DOTS is still our framework in implementation. And we said we are patient-centered. And sabi nga natin, sino pa ba yung may mass responsibility for our children kung hindi yung parents? That's why for treatment partners, train family members as the sole treatment partner in special or exceptional cases would include children. So yung nanay or guardian na yung kanyang treatment partner. So there is no need to go to the health facility every day for the drug intake. Unlike before, we're very strict na dapat health worker lang ang maging treatment partner. Okay? So let's now go to the DOTS referral system. So if we look at the places where our TB patients would be going, so this is based on the 1997 prevalence survey. So TB symptomatics, so they are still not diagnosed as TB case. They would go, 36% would go to the private physician. Only 25% would go to the government health center. Then others would be the traditional healer, family members, or the hospitals. Then among those, or among TB patients, hospitals, 28%, private physicians, 24%, government health workers, 36%. So, patients are having their treatment in several areas. So, we need to have a good referral system for us to ensure that all TB cases are detected and notified. Okay, so we have that in our new MOP. Before, we do not have this, because we want to ensure that cases are really found, no? And started on treatment. So we want to reduce the delay in the diagnosis and treatment. We want to ensure continuity and compliance to treatment, reduce out-of-pocket costs to patients, and to ensure that the patient is registered and notified to the program. So before, kapag may ni-refer yung private, ang sasabihin ng mga public ay umpisa sa case finding ulit yung patient. Uulitin yung smear exam, lahat uulitin. But we consider that in our new MOP. So the policies are, patients shall have the right to know the reasons for referral and participate in the choice of facilities where they will be referred. So hindi lang sasabihin ng health worker na pupunta ka dun sa hospital or pupunta ka dun sa other health facility. So it should be an agreement between the patient and the health worker. Then the healthcare providers have the responsibility of ensuring prompt and appropriate response to patients' health needs by immediate referral of services. So we should ensure that the patients are referred properly. And there should be a two-way functional referral, ensuring that receiving facility provides feedback to the referring facility. So, hindi lang na nag-refer, pero hindi natin alam ano kaya nangyari sa aking patient. So, we should know that. Then, the other policies is, it is a shared responsibility of a referring and receiving facilities to exert all efforts of ensuring that referred patients are not lost, no, during the referral. So, dapat mag-follow up if the patient really reached the referred facility. Then, all referring facilities providers must use a standard referral form. So, we have a form for that. Then, this is the good news. Patients who are not referred in accordance with policies and procedures shall be accommodated and evaluated accordingly. So, hindi ka namin tatanggapin kasi you are not following our policies and guidelines. So, this is part of the new or the revised MOP. So as always, I just would like to caution that when we are revising or if there are changes in the policy, medyo may transition period. Kasi baka bukas, mag-refer na kayo, tapos merong health worker na magsabi na, ay hindi ka namin tatanggapin. We just rolled out our training. Based on the reports that we have, all regions have already done their training for the MOP, so we need to monitor and emphasize the new changes that we have for the MOP. So this is the referral system for TB. So if you are a DOTS clinic, you can have, so if you are a hospital, you can have your TB patients from the OPD department, or you can have your TB patients from the ward. So hindi lang OPD. Dapat kahit nandun sa ward should be already included. So if you are a DOTS providing hospital, so you will enroll and register and report to the NTP. But if you would be only referring, you have to link to another DOTS facility. So this is what we call the internal referral system. So this is within the facility. And the external referral system is when you would be referring to another DOTS facility. And we are emphasizing here the importance of a feedback to the referring facility. Okay. So the question now is, where do we refer our cases? So when we're saying drug-susceptible TB, these services are available in all rural health units and city health centers. So lahat ng health centers. But when we are saying services for drug-resistant TB cases, these are in selected PMDT treatment centers. So these centers could either be a public or private hospital, it can be a health center, or it can be a rural health unit. But our aim is, after some time, all rural health units should be able to provide services not just for the drug susceptible but also for the drug resistant TB cases. And we call that the IDOTS, Integrated DOTS Services. So we are now here to the presumptive DR-TB. So kung merong suspect, who are these? So these are children, those with history of TB treatment, which we call the retreatment cases, close contact of a suspected or confirmed MDR-TB. So even just a suspect MDR-TB case, we should already refer them, or they are included as presumptive DR-TB. Those who failed to improve clinically after 2 to 3 months of first-line anti-TB drugs. So persistence of symptoms and failure to gain weight. And those non-converter of Category 1 or Category 2 treatment regimen. So non-converter are those that are smear positive, or right now we call it bacteriologically confirmed. So ibig sabihin nun, they are gene expert positive for TB, and at the end of the second month, they are smear positive. Since when we do follow-up, we just use the smear microscopy. We don't use the gene expert for follow-up. So these are patients that are still smear positive at the end of the intensive phase. So this would be the flow of referral. So when we identify the presumptive DR-TB, we need to fill out the NTP referral forms, and we need to attach the result of the DSSM, the direct sputum smear microscopy if done, the TST, the chest x-ray, and other pertinent laboratory examinations not done to the patient. Then we refer and contact the DOTS facility with PMDT services. Then the receiving facility shall acknowledge the referral through a referral slip. Okay, so we refer to the DOTS facility with PMDT services. Okay, so where are these facilities? So when we are talking about NCR, NCR has the most number of PMDT facilities. So we have in Makati, TDF. So in Manila, these are the facilities, Muntinlupa, although this is a prison. Then Parañaque, there's a health center, Caloocan, Pasay, Quezon City. So these are the facilities that we have. Then these are the gene expert laboratories. Then for CAR, we only have one, Baguio General Hospital and Medical Center. So Region 1, so we have in Ilocos Norte, Ilocos Sur, La Union, and Pangasinan. Cagayan Valley, so we have in the Cagayan Valley Medical Center. Region 3, Bataan and Pampanga. Region 4A, so Batangas, Cavite, Laguna, Quezon, and Rizal. 4B, so as of now, it's only in Palawan. Other islands like Marinduque, Mindoro, they would refer to Region 4A, that is in Batangas Medical Center. Region 5, Camarines Sur and Sorsogon. Then Region 6, we have Aklan, Antique, Capiz, Iloilo, and Negros Occidental. For Region 7, it's in Bohol and Cebu. Region 8, in Eastern Samar, Leyte, Southern Leyte. For Region 9, Zamboanga del Norte, Zamboanga del Sur. Then for Region 10, Lanao del Norte, Mis-Ok, and Misamis Oriental. Region 11, Region 12, and Caraga and ARM. So as I have mentioned, all regions have PMDT facilities already. Unlike before, it was only here in Metro Manila. Okay? So the main message of the program is we need the help of the private sector, and they can do this by referring your TB cases, or you can provide the service. We just have to do the training and discuss, no, how are we going to implement, since we really need to find and treat and report these TB cases. There are about 33,000 missing TB cases, and we're saying that most of these would be children, since our accomplishment would show that only 10% of our cases are children. And based on the estimates of WHO, it can be as high as 19%. So we still miss the 9%. In terms of MDR-TB, we're only finding less than 1%. And that would be about 4 to 9 cases only in a year. Okay? So we need to stop TB. So this is our theme for the World TB Day. And thank you.